قبل محاضرة إليها المناظرة بين البروفيشنال والدكتور باسل السوشيال الدكتور عادل الدين كارديك سيرجن وكارديك سيرجن يونيفرسيتي ماكماستر. قبل ما نبدا نتكلم عن الصوت عقيده المواطنين بالنسبه للثاني بنديكم شريحه عن اللايف يعني السيرفي لكن هي شو كان حاليا يمكن يتوقع البيشنت يعني سيفير مين كورين ارت ديزيز. هل الروتين اسمه انترفنشن يعني بي سي اي ستيج اللي كويس افضل من باي باس سيرجري. مين يتوقع ان الستيج بي سي اي افضل من يرفع هو وبعدين لما هذه اللي قلتها شو الثالث جدا هو شويه باين يتوقع ان الكابج السيرجري افضل من الاثنين فهو الاغلبيه الكابج انا بس وضع الجواب شويه عاده من الفانكس سويت مشكله في طبعا عندنا الاستقبال اللي بنعمل في القاضي سببيتهم في الكارديولوجي ميديسن هنكون عندنا اكثر سيرجن سايت كانوا يكون دكتور كارdiac سيرجن دكتور منتوش كارdiac سيرجن في عندنا دكتور خالد داخلي ومنتوش كارديولوجيست على بس شوي مع رئيس الجمعيه وعندك هنا اتصال انا عندي سؤال يرفع البروتون كاردياك سيرجن كلهم يرفع البروتون كاردياك يكون وين؟
We're actually very pleased that most of the audience are up to date regarding the surgery.
تساعدني والله يمتك خلاص ليش في عندنا مشبع لا نجيب خليها
السلام عليكم. الديبيت supposed to be entertaining. وصار في نفس كيس 48 فيها عندها تركيز عندها 5 والار سي اي سنتر لو تلاحظ هنا في لما نجيب there's no backfilling to the aorta but there is equal slow downstream. This is a telltale sign that there's outflow, severe outflow left bleeding. The patient has management, they have to work on management. I don't think so. Not sending a very high risk for region. Could be treated with bypass surgery. If it has any desire on that, could be treated with PCI. And is there what's the benefits? أما دي حالة زي هذا طيب يروح الجامعة الجامعية عند عالم الصيون الجامعة الجامعية وشاد يجي سيرجري وفي نفس الوقت الجامعة لازم الصيون الجامعة الثانية وفي يعني كل الإطار. Let's see what we have. الفيجن هذه بيجي عالم السيرجري من البطن نوع الصغار من قصة الصدر نفسها وسجن في الهول شاس. نفس القلب الموضوع اللي مرة واحدة مفروض على ماشين باي باس لتصور الأورجنز وكان هذا الضيق يصير فيها كان الأمور والبرج من ساعة خاص الأرقام اللي جوا وبعد السنة اللي بيسكروا بتبقى في المستشفى حوالي كانت تقدر زمان تستقبل 10 لسه 6 days لسه قبل البيت في ICU. Go home will take about 3 months to get back to baseline, sometimes 6 months. لو كنت interventional cardiologist working in private, you're going to be down for 3 months. You want to get more PCI, which has an impact. Or you always have a medical. I can have a start with the good. And then you will PCI, nothing is بتكون away from the procedure. العيد جاي عبد العيد المرضى بالتالي تزيد بشكل عام. أكيد تزيد بالسيارة كتاب الأمور بعد البروسيجر في الفاكهة تقدم على المشكلة تركض اللي بعده بعد ذلك تركض نفسيا تركض العوادث وكان كده ماشي البدويس اللي بعد ذلك شو معنا فيعني في difference and these are not similar procedures. They have the Mishnah. This is not a randomized trial of drugs. This is not medication A versus medication B. Feed difference. People. Like you said, more previous for recovery. Recovery is the big one. So let's see what the data is. So one of the bigger trials for public decency is the Excel trial. Randomized at 5 years, they randomized about 2,000 patients having to bypass surgery versus PCI. But the patients had to have a low CPAP score. They were thought to be appropriate for both bypass surgery or PCI. And then they were randomized. And they showed that at 3 months, there was no difference in the primary outcome. The outcome was all-cause death, stroke, or MI at 3 years. And when they followed at 5 years, the curve started to diverge, but they were still at 5 years. There was no significant difference. So based on this, probably conclude that patients with reasonable anatomy of both PCI and CABG, either approach is reasonable with no difference in all-cause death, stroke, or MI at 5 years. The other trial is the Nobel trial, and they also published their 5-year follow-up. And this was not as good for PCI. It did show that at 5 years, there was the primary event occurred in 28% in the PCI group versus 19% in the CABG group. 9% that's good difference. So how do we make sense of these two very different results? Well, in reality, the trials are pretty much similar. The big difference was what the primary outcome proposed of. In normal, they included repeat revascularization as a primary outcome. If you look at any trial, any study, the benefit of CABG is reduced risk of repeat revascularization. It's more durable result, and this is that any patient that is considering for PCI having to disclose that their chances of coming back to repeat revascularization will be high. And the Excel trial was not part of the primary outcome, but it was a secondary outcome, and it did show that there was a decrease in repeat revascularization. The normal trial did not measure procedural myocardial infarction. So MI was part of the primary outcome, but only spontaneous MI. I think she did surgery, think of PCI, if you really see it, make see it. We're not going to count that sort of procedure. We're not going to stop. We're only going to count the amount that happened on follow-up. While in the Excel, the procedural MI was part of the procedural outcome, and use their own definition for that. This definition. But 4 points I'm going to cover. Overall mortality, the myocardial infarction rates, repeat revascularization, and the unmentioned complications are not part of the trial. So, because of all the controversy that happened after the Excel and Nobel and Dr. McTaggart going off his rails, so I think that out of the full patient data analysis, meaning the acquisition of patient data from the Excel, syntax, Nobel, and pre-combat. Syntax and pre-combat are older PCI versus CABG studies. And they showed no difference, no statistical difference in mortality at 5 years or even at 10 years. The p-value was 0.33. And based on this, there is no mortality benefit from PCI versus CABG because it's more complex anatomy in which PCI is. And I think this is the fact. However, with bypass surgery, we'll have a lower risk of spontaneous myocardial infarction. And that's been shown again in this meta-analysis. PCI will high, your chance of having a recurrence of mine is higher than with CABG. But that's offset by a higher rate of procedural protocol definition of procedural myocardial infarction, which makes sense. You're on cross-class longer, you're versus procedural longer. It's likely that you'll have a higher chance of procedural MI that is clinically significant and prognostic. Obviously, the rate of lower repeat MI is expected to be higher with PCI because you only treat the significant lesions. But if there are non-significant lesions that are risk of rupture in the future, obviously that gets treated at the same time with bypass surgery, but not a PCI, not a recurring case. Repeat revascularization, there is obviously a number with PCI that will have a higher rate of repeat revascularization. If you have PCI, the rate is about 15%, while with the CABG it's 7%. So the difference is At 5 years, it's less than 10%, meaning that you need to do at least more than 10 CABGs to prevent one repeat procedure at 5 years. Now, repeat revascularization is a procedure, it's not an outcome. And repeat revascularization, post CABG, if the graft goes down using the PCI on that, is a much different much different treatment than repeat revascularization PCI, and that's not captured in the data. And that's why I do strongly believe that repeat revascularization should not be part of the primary outcome in any study. And is it important? Well, for patients, it's not. This is analysis of asking patients what do they think the most important outcome are. Relapse and rehospitalization is the goals. They ask cardiologists what is more important to you. And they also agree. Repeat revascularization and rehospitalization is not as important. So the perception of importance is not tied to the patient. And when you talk to patients about the option, repeat revascularization does not simply mean that they will do that. And at the end of the day, if you have the PCI at the last name, and if you're at a small percentage that it fails, you can always have your CABG on the board if necessary. We don't count the other worst outcomes with bypass surgery in the primary outcomes. Why do we not count the higher risk of acute renal failure, the higher risk of arrhythmias? Patient coming for bypass surgery with heart rhythm fibrillation. Now needs to be on lifelong anticoagulation, might be quite symptomatic with it. Infection rates requiring antibiotics, cold pericarditis, transfusion. These are all things outcomes that are highly PCI. They're not part of the primary outcome, which makes sense. So this patient is counted for PCI. You can see the left knee critical losing rate is quite optimal. Once that was put in, we had an excellent final result. The patient went home the next day. This was 7 years ago, and so far continues to do quite well. So at the summary, both treating the same disease with two different approaches. PCI and Hanan are very different. We treat the same pathology. In patients who, PCI has an early effect. Less invasive is back to work, back to life, with fewer procedural complications and more rapid recovery with better early quality of life. The quality of life at 5 years is going to be equal, but early on it's better with PCI. Obviously, CABG is more durable and seems to have fewer adverse events beyond 1 year, mainly repeat revascularization and spontaneous myocardial infarction. And when both procedures are active, both can be done with low, PCI can be done with low risk, bypass can be done with low risk. That data has to be presented to the patient, and they have to their preference should be taken into consideration. You can't tell the patient it's not have sense, it's bad, it's fair. And the higher rate of repeat revascularization is the source of patient. And I think I will end there. Thank you. Much easier than I thought that.
What's your name? Sorry. حضرتك صح؟
لا هي ترى هنا تعود يعني يا حضرتك
Good afternoon, ladies and gentlemen. Thanks for the invitation. Thanks for the invitation, and it's a pleasure to be part of this conference and among the colleagues and see all the old and the new friends. I think this is a very interesting debate. I think everywhere you go, this is probably the most interesting topic to be discussed among the interventional cardiac surgeons. And I think Basim was very good at showing you what he wants you to see. So I'll show you the other side of the story. And being a surgeon, I think they will be in favor of CABG, of course. So I will tell you CABG is best for patient blessing. And I think this shows. I'm just going to show you what I'm going to go through. So again, we'll do the same thing. I'll show you a patient who is 77 years old with an understanding with diabetes and EF of 40%. we could appreciate this left main and the disease RCA. And by the way, I didn't see a lesion of the osteoblast earlier, so I'm not sure with what it means. I didn't see much in the way of stenosis earlier. I was trying to see what the vision I could try to stand, but anyway, this is clearly a very challenging area. And everybody can tell that this is a significant stenosis. And this is the second case who is 38 few weeks ago, and 81 years old, dialysis, and even failure would be up less than 20%. And we can all see the significant lesion there. So we all know that CABG versus electrotherapy is well established, by the way, by endocrinologist who is actually the head of the division of our institution, Dr. Salim Yusuf. He showed that CABG is superior to PCI, or sorry, superior to medical therapy in those who are pre-facility and left main with a significant survival advantage. And I am going to be asking the audience, do we have a trial comparing PCI to medical therapy in patients with left main? To my humble knowledge and my limited experience, I'm not aware of any of these trials. Cardiac surgeons in the 70s and the 80s have done this, and in fact, they have a patient level meta-analysis in the 90s. And most patients, or most studies, are more unaware of they're executing the left main disease. So for this reason, I think we are both the SDS and the European guidelines being given a level 1 recommendation. Recommendation level A1 and negative evidence A. So let's go to the journey with the study that compared PCI versus CABG in the trial that Pastor mentioned and a few others that he's trying to find. So this is the commonest or the most controversial trials in history. It's published by Dr. Stone, who is a very famous cardiologist. In 2016 was the first publication of 3 years outcome. And the second trial, which shortly was published, which is a Nobel. And we know, I'm going to skip this, I think the Bassam covered this very well. And you can see the exclusion of the repeated revascularization. I can tell that Bassam, he said repeated revascularization is a procedure, but the repeated revascularization also kills the patient. So I think the problem with all these trials comparing PCI versus CABG is always a tricky trials, because cardiologists who design these trials always try to use a composite outcome, which is a way around it to actually minimize the sample size so that we can actually finish the trial quickly. And I think for me, if you ask me why we treat patients, it's not because I want them to go home tomorrow or today or after 2 days. I think I want to see in 15, 20 years without seeing you back and forth. I think that is the problem when it comes to, I think mortality. I agree with people would say for certain outcomes versus others, and also the clinical scenarios and the patient's profile. But I think we all agree that when we deliver care, we have to deliver a high quality and durable treatment. So I think there's a huge controversy about the definition of peri-procedure MR, and I will comment on that later on. So there's a lot of issues with the design and the targets that was used by the Excel trial. I think the biomarker was used, nobody uses CKMB these days in diagnosing MI. I think the audience would agree most of the using proponent, Excel use CKMB, and also use a change of definition while doing the trial. It's been the first time in history where the outcome, the way they assess outcomes changed between the first publication and second publication. And during the trial, there has been a lot of manipulation to make CABG looks bad. And I'll confirm that, and I will see as we go through this. So the first publication showed, as Bassam showed earlier, okay. You can see the crossing, and I think the writing was on the wall from even the 3 years publication. Everybody was ignoring these curves. I've seen it before multiple times, and we just keep ignoring it. So we all can say the difference wasn't significant, and it's only 3 years, which is another limitation beside excluding the revascularization. And determining that your primary outcome is only at 3 years is a big issue for me, because we've seen and we've known that to see an impact, you need to follow the patient for a minimum of 5-10 years. So the European Society jumped and put a class 1 for the first time for PCI to the left main. And if we waited a little bit to 2019, when the 5-year publication came out, there was no significant difference, I agree, but we can see the look of the curve. And Bassett did not want to see that the death from all cause was significantly in favor of CABG. But again, our cardiology will come to you and say, listen, the cardiac death was not significant, but the all cause death was significant. So now we're not only including multi-number composite outcome, now we calculating sample size and the power of a study to detect the difference based on a composite outcome, but we're going to be interpreting a very sub-analysis of a subgroup of so that it suits my needs, which is appropriate for me in all the trials as compared to versus PCI. So that's the person. So there was a difference in mortality and mortality. And there was a difference, and even if you look at the absolute difference here, 19 versus 22, I can tell you, and I'm not sure how many of you are aware of the Plato trial. The reason why you switch from using Plavix to Procanolol in managing acute coronary syndrome is because of the absolute risk difference of 1.5%. So why when we have a more than 3% risk difference, it's not significant. Yes, statistically not. But in your Plavix Procanolol trial, there was only 1.5, and the Plavix went down to the drain. So there was a big issue about the definition of MI, and there was an issue about put a lot of pressure on the authors to try to reanalyze the data and come up with a true estimate of the MI. And that was finally responded a year later. And he came the same author and wrote in the New England Journal of Medicine that with the use of this universal definition of myocardial infarction, not the one that has not been tested and used in the past. In fact, the MI after CABG is almost half. And now we're down from 9% at 5 years to 4.7%. And I bet you that this was added. Unfortunately, he did not publish the composite outcome, including the new data. And he added that it would be significantly different even with the composite outcome. So the reason why some of the investigators withdrew their support, because they used an untested definition of peri-procedural myocardial infarction that clearly penalized surgery, and that is the key driver for the composite outcome that claims no difference in the two treatment strategies. And that's why the American Society decided that they've been smart, because they have to wait for at least 5 years outcome to make the guidelines, because guidelines could throw off people. But if you jump right away and you try putting guidelines, that's what you're gonna have. Now, still you are class 2A and I'm class 1. So that is the difference between the being patient and waiting for the evidence to mature versus jumping and being early decision. And that leads to the former excellent investigator to withdraw his support. He was the section head of the investigator in the trial. And I can read to you what he said when they were interviewed by the BBC. What happened in Excel trial was a disgrace, but halfway through the trial, the definition of myocardial infarction was changed. Interestingly, if you take our peri-procedural myocardial infarction, CABG is very clear, women. I believe the data was manipulated using the changed definition of myocardial infarction to try to prove for the composite endpoint that was no difference between PCI and CABG. And here we go. The European Society of Cardiac Surgery withdrew their support for the current recommendation until it is revised. I think it's in the process of being revised to come up with a new guideline. Just a quick comment on the myocardial infarction and definition they use. They use up to 10 times difference or 10 times the upper limit of blood pressure component with some changes in the ECG or Q weights or renal ischemia to define a peri-procedural myocardial infarction. Our group in Hamilton, they followed more than 13,000 patients in a prospective cohort study and patients undergoing CABG and ABR and other procedures. And they measured performance 1 day, 3 days, and post and followed them. And they found that out of 15,000 patients, there were 2% down. And they looked at the threshold correlate with the myocardial infarction when it comes to the troponin rise. And guess what, guys? You need 218-fold increase of the upper limit of normal to be associated with significant risk of death. And for more than this CABG, you need 500-fold increase. So to define clear procedure in mind and to make it the same between PCI and CABG, it's not clear for the surgeon because I can tell you, come to my operating room, when I ask you to hold that heart, the amount of CTMB troponin that's squeezed is not myocardial infarction. Because if it is significant, it will be captured in the survival in 5 to 10 years. Because whatever happens, any complication, whether I end up with acute renal failure or cerebral infection, it will be captured at 5 and 10 years if the patient is not doing very well. I think I don't know better in my favor, but I'm not going to spend much time because you know what, it's too much for that. So again, it's a clear winner. Same thing. Even in the low syntax score, there's also that we're good in low syntax score. Even in the low syntax score, I don't believe in subgroups. I'm not going to mention it, but just in case of people to read that up. Look at the Novella LCS. You know, same studies. We've seen it before. The drug-eluting stent, Derbi trials, angioplasty versus CABG, stent, bare metal stent, the same result over and over and over. And our technology colleague does not want to stop. You can keep changing. You cannot lump multi-studies and meta-analysis when you're using different generation stent, different techniques, different definition of inclusion exclusion criteria, and lump it together because in all these trials, CABG is the same. Sternotomy, Lima vein, we're all the same. You guys keep changing, and that doesn't add much noise to the conclusion. I'm going to kill you with this because this is not a left main study. I think the study name should be changed because this is a phase 3 trial comparing PCI, which is guided by the gold standard treatment, which is now the FFR. But even that, in 3 vessel disease, when they compare it with CABG, it ended up at even 1 year, not a superior treatment. And I think they should change it from shame 2 to shame 3 trial. So let me guess. The same curve, another twin that was born through the Excel and Nobel trial. What is the impact of incomplete revascularization? The Excel study looked at people who had PCI versus CABG and look at the proportion of people who end up with PCI. What is the percentage of people with incomplete revascularization? More than half. And cardiologists know if you don't end up with complete revascularization, your patient's not going to do very well. And there was something very similar as to what is the definition, even in the CABG population. I have a hard time understanding why there was 27% of people with incomplete revascularization, but nonetheless, having more than half with incomplete revascularization, even in the left main, they're probably distributed equally, is a big concern because that was associated with poor outcome. Look at the PCI with the incomplete revascularization significantly worse. It's significantly worse. The mortality after repeated vascularization, the Excel trial showed that if you have repeated vascularization, your outcome is bad. And that was published by the same group that shows that you actually have a hazard ratio of 2.01 to be to 5 and up to 4.2 for a CPS. So I think what we need to be here, I think what's more important for the patient is we have to be as a team to decide what's best for the patient. I think this is the most important slide in all the conversation we have today. Because I think there are factors that we should focus on to decide which treatment option. There will be some areas or some cases where PCI could push for. There are some cases that feel sorry when the patient gets extended. I think there are anatomical factors, there are probability factors, there are patient factors, and one of them is patient preference. So if you get them like PCI or like surgery, I don't think we can persuade either way or the other. But I think at the end of the day, you need to be very transparent and thoughtful and very, you have the patient have to be very informed with the best available evidence. I think patients And one survey in UK, there was a survey of intervention technologies, only 18% disclosed CABG as an option for treating current disease. And the use of parking rounds is now class 1 indication in the guidelines. I think that this our goal, all probably seen in the passive slide. I think if you have patient with diabetes, for example, no injection fraction, or patient cannot do antibiotics, the CABG is better. If it's somebody whose survival is not that long, acute failure, frail, urgent hospitalization, it probably does PCI. So take home message, the majority of patients with left main disease have 3%, and only less than 10% have left main. So it's very hard to start to extrapolate the data on patients, a very small group, and try to apply it to the practice. CABG remains the gold standard treatment for patients with left main. PCI is a reasonable alternative in selected patient, probably with a syntax score less than 22. Patient with complex anatomy, multiple comorbidities, spray and need to be discussed in a heart team round. Full disclosure of treatment option and transparency is a must. Patient preference, social and cultural factors are important in decision making. We really have, I don't think there's actually even a debate to start with, but I think this is a good point.
So I have 5 minutes to respond. And I will have 25 minutes after. So I think I know this is enough time. Okay. Now, I think this should be a time. I should be moving on with that thought. You have to make this university. Right? Good luck. Infection الموضوع ترى left main مش reversible disease. Once the kind of left main is worse than reversible disease, not wrong. Because the disease means there's a higher burden of atherosclerosis, higher complexity of the matter. The حالات اللي انت وريتهم بتاع left main لو انا جيت كنت بتديهم PCI أفهم مثل those are high syntax complex anatomy. والحالة اللي وريتها اللي كده انت بتكتب left main مش كده. الديب الجيد is no back flow ولا بنكتب PCI كان في ورا. فهذا الكيس اللي انت وريتهم ايه معك. أنا أجيب PCI لما أنت تقول لي من الجيش اللي ما بايباس this is too high. هذا كلام يجيب بعد left main versus medical management. The place اللي قلت فيه left main versus medical management. مثلا في الجيش شو كان medical management برضه؟ كانت نايترو سبراي حتى الأسبوع اللي أنا في الشارع بتتراوح في هذا الساعة لما كلنا even if معناش في temporary left main versus medical management side, and I don't think we'll use one. You showed the slide of the death for all cause in the Excel file. I showed you the death for all cause in the multivariate analysis. Why was there no decrease in death of all cause in novel or in syntax? Because those who are incidental. Those patients that died, when you look at them, they died from sepsis, they died from pneumonia. You can't convince me that PCI increases the risk of sepsis or from pneumonia. Important, and it was patient pool data, not the outcome results. I agree with you. The MI definition part is very confusing. We can talk for a whole conference with top in the MI definition. The UDMI definition shows worse outcomes with CABG, not with PCI, even though the PCI rates are higher. The data that was used in the Excel file is the same definition or quite similar to the definition used in the ischemia file. Yet we accept the result of the ischemia file without any debate showing that CABG is not warranted, but we debated the Excel file. The Dr. McTaggart withdrew his comments, by the way, because it was not true that the definition was created in the middle of the file, it was agreed upon. The problem with the definition itself is it relies a lot on CK and D, which has been shown to be prognostic, but it's not present generally. I agree that there should be, an agreement should be reached to what is a very procedural amount for trial and what would be considered clinically significant. Nevertheless, if we excluded, if we did what Dr. Tiger wanted to do and excluded the procedural amount, and we applied that to the ischemia trial would be positive, then we'd be happy with extending everyone or bypassing anyone with stable pulmonary disease. yet we don't, because it's even powerful that the outcome. Talked about the heart team. I think heart team is nice when a patient has what you said, complex anatomy with high risk morbidity or sudden treatment. However, the patient I showed you, as I said, I know what a surgeon is going to tell me. The surgeon is going to say this patient should go for bypass surgery. But well, wait a minute, this is very low risk anatomy. PCI can give a good result and a durable result. And you know, if the patient's accepting that there's going to be a higher rate of repeat revascularization, that should be offered as well. So unless I think surgeons are great in deciding that patients you know, can offer surgery for patients who have high risk or not. The lowest rate that RT discussion theoretically sounds nice, but it doesn't really end up being very believable. You know, when you put a graft in, you put a vein, great, but you also put a vein graft somewhere else. Those fail. There's 1 year, 20% of vein grafts fail. And we don't repeat revascularize them because they don't do well with repeat revascularization, and we stick to medical management, which while we had a PCI, which we had PCI and a symptom there, it's very easy for us to restent them. Any interventional cardiologist in the room will tell you repeat revascularizing after bypass surgery is very difficult, poor outcomes, poor results. Repeat revascularization post PCI in the majority of patients is, you know, is not a big deal. And thank you. So I think the problem is here that, for example, when it comes to what you mentioned last about the graph, for example, let's start with the last point. I think you can use a brain graph as a lab, but I think prognosis is not significant. Because we know 60% of the heart is supplied by the LCS. I think we know that the biggest objective is we know how to do that. I think most of the time, even if you start tapping or seeking our patient post-hospitalization, I think depending on where you practice, if you come to Canada, for example, in the US, people do CABG 6 and 7 and 8 and 5 every day. If you tap those guys, you'll see 2 or 3 gaps are down, but prognostically, I mean, the key is here is whatever happens, it will show if you follow your patient in the long-term result. So I go over and over, and our center debated this, including a lot of prominent cardiologists, some of them probably known to you guys, that the best trials should be done to compare mortality, but that will need 4 to 5 to 6,000 patients to have a power of at least 80% to detect the difference. If you guys keep having competent outcomes, and I think that is if we want to solve this, I think we should try to start adding noise to the outcome. I agree with you with the medical therapy versus CABG in the 70s, but I think, you know what, it was the same thing, applied to both sides. Medical therapy was, beta blocker was yes, maybe just aspirin, but again, you've done the first trial, you were better than the medical therapy. And if you guys current you're not, I think you're stable current disease, you don't stand it, because if you stand it, there's no difference compared to if you go and aspirin. So that is my message. I think for us is we need, if you want to continue to debate this or study this, focus on mortality, because mortality is the best thing for our time. But we need to include unfortunately 6 or 5 or 4,000 patients, and none of your drug company wants to sponsor.
Dr. Adil على this very interesting and high standard debate. باسم جميع القلبيين نشكركم على وجودكم معنا، شرف وجودكم معنا في هذا المؤتمر، شرفنا انضمامكم لجميع القلب. This is the talk from جميع القلبيين. هذا الدبيت طبعا أنا أكيد سمبتي ومتعاطف جدا مع التارجت سيرفيس. The abuse patient in the past. To start with, there was only capital. There was no statement. Then 1 visit, 2 visits, 3 visits. Then left main intervention. Then therapy. Then what? They are losing patients, and I think sympathy. They spend a lot of time. They spend a lot of time to them, and then to them the skills to have surgery. And then now their hands getting rusty because they didn't have enough patients. and I sympathize with that. Sympathize with them. In the talk about this mainstream, we have most of the agents are general cardiology. I think we have to divide this mainstream intervention into three: osteal mid-lane, and then distal lane. In osteal and main stenosis, you cannot argue that PCI gives the same result, or sometimes better than coverage, in a way that you reduce the in-hospital morbidity. And the patient has PCI to the hospital and get mid-lane and then dressing home next day. If you have surgery, you're going to have 2 days in the ICU and then another 3 or 4 days in the ward, and then you spend another 3 months to get back to normal life. But as you can see from X-ray and model, if you have osteal and mid-lane, you can have the same results, but better quality of life. This lane, we cannot argue with. It's a hard box and takes a score, established better than PCI. We will not argue with it. Okay, thank you.
The problem with this file usually comes to the definition. As Dr. Basim said, he wasn't happy with the endpoint revascularization. Revascularization, I think, is a hard endpoint. If someone gets revascularized, you cannot say he's not or not, he did or not. And it's not easy decision for cardiologists to revascularize or surgeon to revascularize the patient damage before. So I think it is a valid endpoint rather than perioperative MI or not, because this is still ill-defined endpoint. The same goes to the mortality. Hard endpoint, you cannot argue about it. I think, as Adil said, every few years we see new trials, but again, they look the same. The graphs almost similar. But then the cardiologists will come and say, no, I think we introduced new technology, a new stent. But my question to Mr. Basim, do you calculate syntax score to every patient, and do you present that in your heart team for every case? We are talking about left main or three-vessel disease.
Yeah, if a patient goes to the complex care routes, which is our heartbeat, if it's referred to that, then the syntax score, the SDS score is calculated for every single patient. Now, unfortunately, that's not a big part of the patients that we end up doing. If I have a patient that I think I can offer PCI, I look at the antigen, I think PCI is doable, I will calculate the syntax score to document. If I look at it and I think bypass surgery is better, then I go with my gut feeling. But then if the surgeon says that we're high risk, then that's different. But if the case I think I can offer PCI for documentation, I'll calculate the syntax score. It takes me 2 minutes.
To calculate syntax score.
Yeah.
2 minutes, and you do it for every case.
For the cases that I think I can offer them PCI. So if a case looks simple, and I think PCI is a reasonable option, to confirm that, I will calculate the syntax score. If the patient looks surgical, then there's no point.
What do you mean, sir?
I mean, this is the left main bifurcation with type of
In terms of
calcification.
syntax score.
Hmm?
In terms of syntax score, what do you mean? Symbol.
Ostial left main, distal left main, that doesn't for the core.
The score.
Oh, that's the 4, that's the 22. That's the 20. If it gets to 22, the 22 between, if it gets to the intermediate part, I start thinking a bit more. But if it's less than 22, absolutely, I'll document the most syntax score. I think PCI would do well.
And though you think still CABG will offer the same result.
I think repeat revascularization, well,
for less than 22.
what was the question there? I lost it there.
Less than 22,
Yeah,
they are similar. CABG and
No, even with low syntax, I still think at the end of the day, if there's mild disease in the distal mid-RCA that we don't fix, or in the mid-LE that we don't fix, there is a certain number of those lesions that will progress with time and will need repeat revascularization. Which, as I said, if it's clinically warranted, usually would be easy to do with PCI, even though I have presented those results. If it was a bypass surgery, repeat revascularization, we tend to stay away from it. So our threshold for repeat revascularization is much higher post bypass surgery, and that doesn't get captured in the trial.
Okay, all right, just a quick comment. First of all, thank you very much indeed for both speakers, and I like the concluding slide by Dr. Adil, which is a fantastic editorial published in the New England Medicine. Let's say the debate is over. So the debate is really over. The other issue is cost, because in Libya, and all audience members, you find patients sitting in their homes or land to be able to go and get a multi-vessel PCI. And if he has 15% every 3 years to have a repeat revascularization or readmission, there's 30% every 3 years. That means 100% within 10 years they'll have to come back and find another house or another piece of land to sell to come back for bypass surgery. These people are best advised to go straight for a definitive treatment, which is open heart surgery. As far as sympathy is concerned, you really have to do story also for the cardiologists. Because in the beginning, all what they can do is do an angiogram and call the surgeon. This patient needs surgery, has treatment. Then they came up with the balloon. Great, the end of surgery. Balloon, it was perfect. Then you realize the balloon, after the balloon collapsed, and patient come back with acute MI, some died, and some need surgery. Then, well, we know balloons are good, we have something new for dermal stent. And then came Barry. Barry killed all chances with dermal stent. After Barry, we have all the study, and I think the last trial was the phase 3, which really put the lid down. If I was a cardiologist, I'd be extremely worried about my career. Thank you. Interventional cardiologist.
Really show kind. Many things in the PCI to give you many disease, better options. You have to ask Bassett to stand
أنا إيش السنتين التايم ولا التايم من السنتين خلاص نفس السؤال اللي قبل المحاضرة المريض اللي عنده severe left main coronary artery disease لا invite question
I cannot find a surgeon to I'm afraid of the patient with I want to be Msalam. There is no surgeon that they will operate on the person. Stop. It's not the question.
Your point is very taken. The circumstances can play a factor, but let's focus on the scientific or the evidence-based. We're in the era of evidence-based medicine, and we all want the best for the patient, right? Either PCR or CABG, we want to treat the patient's life-threatening disease. Let's keep a simple question, okay? Who thinks for severe liver disease, PCI is a better option? Stent is a better option. Okay.
Give an idea to the
One second. I'm a general cardiologist. I'm not class. I'm not a surgeon, not a surgeon. Okay. I think most of the audience here, they're general practitioners in medicine or prevention. But in Libya, after listening to the debate, what do you think is the better option for severe left main disease? Stent If you think stent, raise your hand. In Libya, yes, in Libya. Okay, okay. More hands than before, okay? How about the same question? In Libya again, CABG. I would say it looks like 50-50. But here's, I think another session starting now. Please hit to the whole beat. This session, ACT mimicker, great sessions are waiting. Tomorrow, مسابقة المستشفيات الجديات تكون adult jeopardy هتكون هناك in the afternoon. But teams doesn't get ready, okay? Thank you.
الساعة 8 فعلا.
Good afternoon. Please be seated so we can start our next session. We will start the next session with the Huda Zaid. Dr. Muhammad Abdullah, unfortunately, did not show, so we will give Huda the time. She will be talking about cardiac disease in women or women and heart disease. Dr. Huda is a consultant cardiologist in Benghazi Medical Center. She's also teaching staff in Infective Medicine, University of Benghazi. Dr. Huda. Assalamu alaikum. Today I will talk about women and heart disease. A problem with a large magnitude and risk of autonomy. I will talk first about abuse, the problem, conversation, risk factor prevention, diagnosis and treatment. After this, the cause of death in women, the Europe and worldwide, heart attacks in women which account for 1/3 of all female deaths globally, have worse outcomes and higher mortality than men. You know, 55% of all females are caused by cardiovascular disease, each year, heart disease kills more women than men. This cause of death in the USA, and cardiovascular disease accounts for 45% compared to breast cancer for breast cancer. And the fatality rate here, male in red and women in gray, more in women. Unfortunately, the risk of women is underestimated because the perception that females are protected against cardiovascular disease, but this protection plays a role in leaving women vulnerable to develop cardiovascular heart failure and stroke. The prevalence of cardiovascular disease in America had in 1992, 2002. At early ages, male in red dominate. After that, start to be utilized at 60, to be more in females at 70 and 80. This cancer is often reported by the media as a major cause of cardiovascular claim nearly 2 times more female lives very young, يعني أكثر 10 مرات الdeath من cardiovascular disease compared to this cancer. Yes, compared to men, women with cardiovascular disease are typically underdiagnosed, undertreated. Why? Maybe due to differences in the etiology and clinical presentation of cardiovascular, leading to misdiagnosis and dismissal of symptoms as related. For instance, women are more likely to visit with myocardial infarction even in the absence of obstructive coronary disease with coronary artery dissection or cardiovascular cardiomyopathy. Risk factors, as we know, age, dyslipidemia, family history, diabetes, smoking, hypertension, and more specific for female pregnancy-related preeclampsia, gestation diabetes, preeclampsia and preeclampsia is considered to be a factor for coronary artery disease and functional hypertension. History of cancer, depression and stress, and history of trauma or abuse. Women tend to have higher incidence of adverse drug reactions, and we will talk about physiology. Complex effective pressure fits or drug intervention may be the cause. Six difference in how to treat medications and absorb medical medication for the skin. Cardiovascular disease started with atherosclerosis. Six difference in role in physiology and presentation of chronic cardiovascular disease. Blood pressure is more common in men, but blood erosion is more common in women, which is an acute syndrome, very clear identity. Once women reach newborn, the incidence of blood pressure increases. Hypertension, high blood pressure is significant risk factor for coronary artery disease, independent risk factor as we know. By the time women reach newborn, women no longer have an advantage over men in hypertension incidence, and the most likely reason is a decrease in the protective effect of female sex hormones as a result of menopause. Coronary artery disease, angina is the most common presentation of coronary artery disease among women. Some reports metabolic syndrome distribution of coronary artery disease in women than obesity. Women with acute coronary syndrome have higher C-activity and PLD, but men have different elevated biomarkers. More small visits they have, i.e. women, vascular inflammation and congestive heart failure, but men, more blood pressure, greater pitch combined and microembolization. Peripheral artery disease, Men have higher risk for peripheral artery disease, as you know. Up to 60% of elderly women with peripheral artery disease are completely asymptomatic. Hypertension is an important risk factor for peripheral artery disease, and women have a higher age-adjusted risk factor, another good. Myocardial infarction, recent studies have compared the risk factor in arterial. The stress of this factor is equally among men and women, with exception of diabetes, which is more strong, much stronger association to female, up to 3.7-fold increase compared to the males. Diabetes because of risk factor 2 times. Women are more likely to have a recurrent MI and be disabled by heart failure and recurrent heart attack. And 58 of women, compared with 25% of men will die within 1 year after heart attack. So the women have less severe obstructive lesion, more vasospastic disease, smaller vessel and institute number. Arrhythmia, the effect of 6 hormone receptor on heart muscle and physiology is different between men and women for sure, and leading to the frequency interval in men after but frequency interval in females. Women have shorter atrial retraction after menopause, and women have slight higher incidence of atrial fibrillation, which it could more stroke related to age. Heart failure at age of 40, women have higher risk of developing heart failure. Why? Hypertension, steep relationship between blood pressure and blood volume, and more vascular dysfunction. Cerebrovascular disease, compared with men, women have a double risk of dying from CA. More than 60% of all strokes death in USA. Women older than 60 years with diabetes and CA lasting after an actual minute, more likely to have stroke. Spontaneous coronary artery dissection can typically affect younger healthy people, particularly women in peripartum or postpartum, and men appears after extreme physical activity. In more than half of cases, life-threatening. Diagnosis is complicated and carry a lot of twitching, chest pain in young women. In more detail, after risk factor for coronary artery disease in women with all coronary events signaling by risk factor. Many tools to assess risk factor are effective in predicting MI risk in women, maybe in a study more than after. The family history of severe risk is different according to gender. But we have modifiable and non-modifiable, and but non-modifiable risk factor can do nothing. Age, can be history, race, history of coronary artery disease before can do nothing. But regarding the age, as mentioned before, men have higher risk of coronary disease than women, but at age of 60, years risk equalize and they become higher for women. Family history exhibits different in men and women who have under investigation, which have happy male, first degree male, in family to old age. Race, ethnic background, African American, Latin, Asian, have more risk factor. Race and ethnic group can do nothing regarding race and ethnic. African, Latin, Asian American has more risk factor than white women. هنا طبعا السوشيال ايكونوميك obesity, access to medical service, treatment, awareness about the disease in these poor ladies. The cardiovascular disease was for male and female. هي من 79 لعند الدراسة لعند 93 was made more with years بدأت الألارم إن females more disease trend mortality من cardiovascular disease. So هنا عندنا شغل احنا عن الموديفايبل risk factor we can do a lot regarding the lifestyle. الويت البودي ماس index value 25 الويت ستيت أكثر من 35. Women who smoke stop smoking. طبعا women who smoke 25 high risk than men who smoke. Obesity increases metabolic syndrome وبالتالي diabetes and cardiovascular disease. الهايبرتنشن يقولوا إنه هو
هي نفس الشيء.
potentially modifiable. We can do something about the sound, medication, reduction of treatment, behavior modification, but still women are under treatment. Smoking, females must stop smoking at any age. Smoking alone increases by 55. Smoking cessation was achieved 56 reduction in mortality, ولو إن يعتبر به شوية. Smoking leads to increasing high blood pressure, suicidal tolerance, increasing tendency to blood clot. diabetes type 1 and type 2. طبعا كده type 1 هو non modified بيعتبر، لكن type 2 اللي هو more common عندنا you can consider it modifiable. You can do something regarding strict control. As I mentioned before, there is a significant factor of vascular disease. وده بيدرس frequently chronic artery disease. وincrease the risk of female 3 to 7 times compared to 2-3 times in males. Ladies, LDL more predictable in men, HDL more predictable in women, low HDL and high TG triglyceride are stronger predictor of heart disease. High triglyceride more likely to die of heart attack and are important marker for chronic artery disease risk in women. Statin has a lot to do treatment-wise. Psychological factors very important in male women with angina have a high diabetes level. Depression is a risk and outcome of heart disease. Women might experience more psychological burden after acute cardiac event than men do. Sleep disturbance, fear of death, or they are doing because of this anxiety and psychological depression after carriage, disabling and fear and depression. Presentation in both sexual pain is most common symptom. ممكن نوصل شوية في الفيميل lightheadedness, more GIT, cold sweat. So it is milder and atypical symptoms in women. Later in course, اللي جانا متأخر طبعا في males she tolerate much أو ما تقدرش حد يشيلها. More comorbidity, more heart failure, tachycardia, early death during ischemic, sudden cardiac death, and signs of non-total and presentation. Diagnosis of ECG X-ray. We have a little talk about exercise G. We study score our results done on males and female and the shape limitation فيها because of weight, because of joint problem, osteoporosis. نحن ممكن نسكت شوية على السنسيتيفو ونقدر نعيش. And this one currently angio for diagnosis and solving the problem at the moment. And others, all of them say in male and female, but others seem to be after the female and female disease is non-obstructive generally and more communication. Pregnancy have to be because of this, other than obstructive tone. Radiation engine to have to consider the diagnosis. Congenital heart disease nutrition group, we look a lot of mothers and their babies, so we need to focus عليهم. The device different physiology, this implantation, حوالي 3 سنة, more complication, intervention treatment, less referral, high complication, do we cardiac no intervention, long-term survival with cardiac fibrillation. Age and sex affect contract-induced renal injury, women smaller and older age عندهم comorbidity at presentation تكون معرضات أكثر للrenal impairment and breathing problems. Breathing complication because of smaller active vision, older diagnosis. CABG, more men, women had significant higher in-hospital mortality and out high morbidity, misuse of internal memory act. Cancer of cardiovascular, زي ما حكيت الدكتورة منى، نفسها في الصبح، toxicity chemotherapy على المصل combined myopathy and heart failure, radiation, pericarditis, وممكن بعد 10 سنين إذا حتى بيستمر. Hormone therapy طبعا not advised. ممكن يلعب small dose for special population for short time. Prevention, we have to work on risk factors by eating right, physically active, not smoking, and keeping healthy weight. You can lower your heart disease by treat diabetes, hypertension, dyslipidemia, reason for the depression. Prevention, pharmacological drugs with activity, increase awareness and screening. Conclusion, gender differences in the use of cardiovascular disease. And also gender difference مهم جدا. Evidence-based guideline providing framework with the society. Take home, coronary artery disease and cardiovascular are by far the biggest risk for women. Awareness is still less than to be. Prevention can reduce risk. Three programs are advisable. Women can behave differently and do worse if they do. Reference, more complications, future consideration of pregnancy. Recommendation, please research at least women cardiovascular health, better understanding cardiovascular disease delay, prevention and care, support for awareness, specific education in nursing and healthcare professionals, and increase the number of women in cardiology professionals. And thank you.
دكتور عثمان المازني okay, Zaid is the general cardiologist working in the PMC. He will talk about infective endocarditis changes in practice.
Infective endocarditis changes in practice. First of all, I'd like to mention a very important point. It's very difficult to summarize the guidelines, the recent guidelines, and the recommendation just within 15 minutes. I tried to cover all aspects of infective endocarditis regarding changing drug prophylaxis and management and referring patients to the cardiac center. First, in my presentation, I'd like to start with prophylaxis, which is very important, and we have to stress this point, and we make it clear to the all general practitioner and cardiologists. All of you know that guideline has been changed recently, and they try to minimize non-needed prophylaxis, and they just the list of indication of prophylaxis becomes very, very short. It's called patient with prosthetic valve, including transcatheter valve for those in whom any prosthetic material was used for cardiac valve repair. Patient with previous episodes of infective endocarditis, and patient with congenital heart disease. We are going to divide them into two groups. There's for any cyanotic congenital heart disease, any type of congenital heart disease repair with the prosthetic material, whether placed surgically or peritoneally, up to 6 months after the procedure. If there is no residual or if there is no significant valve, but if there is residual, we have to continue with this prophylaxis for life. Non-specific measure or non-specific prevention measure to be followed in high risk and intermediate risk patients. I mean, high risk those who are have clear indication of prophylaxis. This measure should be ideally applied for general population and particularly reinforced in high risk patients. Even general practitioners and even nurses should know this. Strict dental and cleaner hygiene, dental follow-up should be performed twice a year in high-risk patients and yearly on the other. Disinfection of wound, eradication or decrease of chronic bacterial carriage of infection. Curative antibiotic of any focus of bacterial infection. No salt medication of antibiotics. It's a very important point. They're trying to minimize the resistant strain. Strict infection control measure for any at-risk procedure. The scourge, burden, and peritoneum, which is also one of the disposing factors for infection. The last point, which is I think that's a very important point, especially here in Libya, limit the use of infusion catheter and invasive procedure when possible. Favor peripheral over central catheter, systemic replacement of peripheral catheter every 3 to 4 days. This is very important point because recently we've seen a lot of patients, they do just central line with no clear indication for central line, which is make risk of different happen. Strict adherence to the care bundle of central and peripheral calendar for recommendation of prophylaxis convention to conduct in high risk patients according to the type
of procedures. I mean, we have to, cardiologist, he has to have a bridge between the cardiologist and dentist. Cardiologist should know the type of procedure, then who the dentist who are going to do it. Dental procedure, antibiotic prophylaxis should only be considered for dental procedure requiring manipulation of gingival or peri-apical region of teeth or perforation of oral mucosa, which is class 2 recommendation. I mean, the other, this is the yellow box. Antibiotic prophylaxis is not recommended for the local anesthetic injection or non-infected tissue. For example, simple wound in the gum or dental X-ray, for adjustment of removable teeth, deciduous teeth, or trauma to lips. This is class 2 recommendation. This should be prohibited. Why is prohibited? Because we are going to restrict the use of antibiotics in specific indications. We try to minimize the emergence of resistant strain. Non-dental procedure, there is no compelling evidence that bacteria resulted from non-dental procedure. Yani, respiratory procedure, gastrointestinal procedure, all of this, there is no indication for antibiotic prophylaxis in this group. All of we know that two types of common antibiotics are used. If there is no penicillin allergy, we are going to use amoxicillin or penicillin. If there is a penicillin allergy, we use the clindamycin. Recommendation for antibiotic prophylaxis for potential local and systemic infection before target or possible infection is very important in our field. Preoperative screening of major carriers of Staphylococcus aureus is recommended before elective target surgery. Class 1 recommendation. Potential source of sepsis should be eliminated more than 2 weeks before the implementation of device, unless the procedure is urgent. The antibiotic prophylaxis should be considered in patient undergoing surgical or transcatheter implantation of prosthetic valve, intravascular prosthesis, or other foreign material. Systemic local treatment without screening of Staphylococcus aureus is not recommended. You now need to give systemic antibiotics. This is very important point I'd like to raise, especially here in my country, endocarditis. All the countries that follow this, and all guidelines, I mean, European Society of Cardiology and also American guidelines, they stress about what's called endocarditis scheme, which we don't have here. Endocarditis scheme is not a endocarditis is not, we know that endocarditis is not a single disease. We know that endocarditis patient may first present to the rheumatologist before cardiologist. So we should know the importance of other specialty other than cardiology. There are very high level of expertise from practitioners of several specialties, including cardiologists, cardiac surgeons, infectious disease specialists, microbiologists, to guide us regarding antibiotics, neurologists to treat, neurologists and neurosurgeons to treat complications, experts in congenital heart disease and others. When we need endocarditis, this is very important. When we refer a patient to the endocarditis, for example, you treat a patient in the city away from traveling. First of all, if patient present with complicated infective endocarditis in the form of heart failure, abscess, thrombotic or neurological complication, or congenital heart failure, should be treated immediately, early, and managed in reference center with an immediate surgical facility. The other group, it's not mandatory to send them immediately, but you should open channels. I mean, you treat your patient with you under with opening channel with this team, within the cardiac team, and just in case you may need them anytime. Facility required in reference center. Immediate access to diagnostic procedures will be possible, including transrapid cardiogram, transesophageal, multi-site CT scan, MRI, and nuclear imaging, because as we know that multi-site CT scan and change even your criteria. Immediate access to the cardiac surgery should be possible during early stage of the disease. Once you diagnose endocarditis, you have to discuss this with surgery even before appearance of clear indication of cardiac surgery. In case of complicated heart failure, abscess, large vegetation, neurological ongoing complications. separate specialists need to be available in this team. يعني team هذا يكون متكون من group of specialty other than cardiologists, cardiac surgeon, infectious disease specialists. Also, you need people who are expert in this nature extractions. This is in case of particularly carditis related fight, and people who are expert in congenital heart disease, and neurologist and neurosurgeon. In fact, even interventional neurology to treat complications. Yeah, this is the team of endocarditis. Diagnosis. Just I'd like to summarize the main point to diagnose endocarditis, other than clinical picture, laboratory finding, imaging technique, echocardiogram, the first and the main imaging modality. Multiplied scan, MRI, neurological, microbiological diagnosis, which is very, very important. And unfortunately, we underestimate the value of this society. Diagnostic criteria, definition of infective endocarditis according to modified new criteria. Modified criteria define the group of infective endocarditis to the three groups: definitive infective endocarditis, which is the clear diagnosis microorganism demonstrated by cultural or physical examination of vegetation, whatever the site of vegetation, intracardiac abscess or physical examination showing active endocarditis. The clinical criteria should be two major criteria or one major criteria and three minor criteria or five minor criteria. Possible endocarditis, this is the gray area. This is between both diagnoses. One major criteria and one minor criterion or three minor criteria. Rejected diagnosis, I mean, you have to visit when you find alternative diagnosis or resolution of symptoms suggesting infective endocarditis with antibiotic therapy less than 4 days, or non-pathological evidence of infective endocarditis at surgery autopsy of antibiotic therapy less than 4 days. Doesn't meet criteria of possible infective endocarditis as mentioned above. So this last group is rejected diagnosis, not diagnosis of endocarditis. Major criteria, just remind you with the major criteria, blood culture positive endocarditis and imaging positive endocarditis. And imaging is also very important point. Blood culture endocarditis according to the type of organism, typical organism, as we know, it is very dense community acquired organism consisting of infective endocarditis with the fertility positive blood culture, more than 2 positive blood culture, samples with more than 12 hours apart, or 3 or majority of more than separate culture of blood. Single positive blood culture for coxilla or phase 1 and immunology antibiotics more than this is definition of term used in diagnosis of endocarditis. This is the imaging part of endocarditis, not microbiological diagnosis. Echocardiogram finding, which is include vegetation, abscess, aneurysm, intracardiac fistula, valvular perforation, aneurysm, new partial dehiscence of prosthetic valve, abnormal activity around the site of prosthetic valve, and from here it comes the importance of 18 fluoride PT scan, which very important to diagnose, and we can collect one of the major criteria from this modality of imaging. But you should know the time of surgery. Yani, if prosthetic was implanted more than 3 months, you can use this type of imaging. Definitive paravalvular lesion by cardiac CT scan. This is the main criteria we know: exposing factor, fever, temperature, vascular phenomena, neurological phenomena, and microbiological evidence with the positive blood culture not consisting with the typical organism. This is the main criteria. This is the predictor of poor outcome in patients. When you say this, when you say patient, we know the predictor depends on the age and the clinical condition of the patient. Presented heart failure, septic shock, echocardiogram finding, which is carried before prognosis. We have just 1 minute. I'd like to go. This is the type of antibiotic we are used in the empirical treatment and treatment according to the MIC, which is called minimal inhibitor concentration. The minimum amount of antibiotic which can inhibit the bacterial growth. Surgical therapy, when you repair patient immediate surgery, heart failure, either aortic or mitral valve, native or pacific valve with refractory pulmonary edema or calcium shock, aortic or mitral valve with the significant regurgitation or obstruction causing symptom or hemodynamic intolerance, or this should be emergency surgery, uncontrolled rejection, either locally by access or force urine or technically by vaccine. Prevention of embolism, one of the clear indications of surgical intervention, aortic or mitral valve, when the vegetation becomes 10 millimeter in size or more, despite antibiotic therapy. To do or not to do, very important message from guideline, or just we define this point when we do prophylaxis. Type procedure. Diagnosis. Transplant beyond recommended is third imaging modality in suspected endocarditis. So it's recommended all patients with clinical suspicion of endocarditis and negative non-diagnostic transplant. And you have to repeat it if you have high suspicion of endocarditis after 5 to 7 days. This is the indication of surgery. The update on guideline. This is the last question. Okay. The update in the neurological complication after this is the one of the recommendations after sign and embolism ischemic tract cardiac surgery. If indicated, should be done without delay. You should not delay the surgery just because patient has CBA. Neurosurgery or endocarditis therapy are indicated for very large interruption intracranial infectious aneurysm, interventional neurosurgery. This you have to delay the surgery just when there is evidence of intracranial. Otherwise, we should not. This is very important topic. Carditis related to endocarditis. We have just to stress very important point here: prolonged before and after extraction of therapy with complete hardware. I mean, device and removal, not just device. Very clean extraction is recommended. That's one recommendation. After extraction, the assessment for need of rehabilitation. Temporary patient is not routinely recommended. We should avoid this practice. Routine antibiotic prophylaxis is recommended before device implementation. Use of antibiotic therapy, interruption of antibiotic therapy is recommended. In intracranial, we should stop all anticoagulant. Thrombolytic therapy should be prohibited in cases between the products. I'd like to finish. This is one of the cases who are presented to us. 22-year-old man. It's a very sad story here. Hanan Tripoli. He's IV drug abuser. Diagnosed as a case of victim of endocarditis. Left side of the victim of endocarditis with left to right ICD interactive system defects. But unfortunately, after we diagnosed this patient, we refer it to the public hospital. But unfortunately, they do surgery. This is and they delayed the diagnosis of the intervention of surgery, and unfortunately he died. That's why I try to stress about the importance in the endocarditis. Thank you.
Next speaker, Dr. Hawa Derbi, consultant family medicine, veterinary polyclinic, director of cardiovascular disease unit at the National CDC, talk with you on ECC prevention guideline.
Today I will present the 2021 guidelines on cardiovascular prevention and symptom factors. I will concentrate on the questions and I can see the video. Introduction associated cardiovascular disease is major cause of morbidity and mortality worldwide. We unhealthy lifestyle and lack of exercise, to prevent ASCVD, to promote healthy lifestyle throughout life and risk factor treatment. What 2021 CBD prevention guideline? It's a single guideline prevention for primary care and hospital care following and supporting clinical health, aimed to reduce burden of the CBD in both individual level as well as population level. Prevention of ASCVD occurs in averagely healthy people or people with cardiovascular disease risk factor. Reducing the progression or prevention of new ASCVD in patients with already established ASCVD. Example, patient has MI, not to have a CDA or other MI. This is the class of recommendation which all we know about, used in this guideline. What's new in 2021? We have stepwise approach to individual cardiovascular disease prevention. We have score 2 and score 2 OP for geographical region, age-specific risk shot apparently healthy people, estimation lifetime cardiovascular disease risk and treatment benefit as option, shared discussion making by taking patients specific conditions, preference, lifestyle, cardiovascular disease risk, treatment benefit into account, recommendation and environment, and thinking cost issue. What do we mean by apparently healthy individual? This person without established ASCVD, no type 2 diabetes, have no chronic disease, no familial hypercholesterolemia. While the patient, when we say the patient has established ASCVD, means that he has clinically or by imaging. Clinically, we have cases in MI or acute coronary syndrome, stroke or LA, aortic aneurysm or peripheral arterial disease, any arterial vascularization, or by imaging made in coronary angiography, CT, coronary, or in carotid ultrasound detected that way. This graph is summarized the structure of the guideline. First, prevention for all, and then we do risk estimation. Prevention for all means decrease blood pressure less than 160, stop smoking, healthy lifestyle. We have the people who may be apparently healthy or ASCVD or have disease condition as diabetes from kidney disease, familial hypercholesterolemia. These patients will be presented with. Then after we do cardiovascular examination, we have put in mind risk modifier as psychological stress, epilepsy, imaging, and we have more than 10 risk modifiers. Comorbidity as cancer, obesity, and if they have inflammatory disease, mental disorder, specific conditions. We do informed discussion with patients, sharing the treatment options. We have the informed discussion means to explain to them the benefits of treatment and the risk of not treatment. We personalize the treatment according to the characteristic of the patient to reach individual level intervention and treatment goals and population level. All of these are reduction cardiovascular disease burden. How we reach the patient how we reach the population which they are targeted for assessing cardiovascular risk factor. It's by systematic screening or opportunistic screening. Opportunistic screening means the patient came not for other reason, and we do ASCVD risk screening. While systematic screening is done in general population as part of formal screening and also program hypertension, or in targeted subpopulation patients for major cardiovascular risk factor, results in improvement risk factor, but no effect in cardiovascular outcome. In patient with the highest risk, cost-effective, and prevention of new cases. This is the recommendation for the cardiovascular risk assessment. If the systematic global cardiovascular risk assessment should be is recommended, and is recommended. People with more than 40 and for male and for female, and more than 50 for female, where they have no factor, we can do systematic or opportunistic. If they are normal or they are low grade, then the risk assessment is not one time, it's maybe repeated. Systematic cardiovascular risk assessment less than 40 female and women less than 50 with no cardiovascular risk factor is not recommended. The stepwise approach to cardiovascular disease prevention, we have step 1, as I said before, prevention for all, then estimation cardiovascular risk factor, consider risk modifier, time, lifetime, treatment benefit, patient referral to reach the prevention goal. Step 2, intensify prevention according to 10 years of cardiovascular risk, taking in mind lifetime or treatment benefits for comorbidity and patient reference to reach the ultimate goal. The category of individuals considered for prevention, we have an adult healthy people, which we are going in, and patient with established ASCVD, patient with diabetes, patient with specific risk as chronic disease or familial hypertension. We will concentrate in apparently healthy individuals. As we see, all prevention goal for all means decrease the blood pressure less than 160, stop the smoking, and then we will estimate the 10 years and healthy lifestyle. For less than 50 years age, we estimate 10 years using score 2. From 30 to 90, also score 2. Estimate 10 years cardiovascular risk score 2. For more than 70 years, we use score 2 open. Open means for all patients. Estimate risk for, why we estimated the risk for CBD and risk stratification to identify patients who will benefit most from ACVD. Risk factor treatment is central to ACVD prevention effort. The highest absolute risk, the highest benefit. The treatment, the lower number needed to treat to prevent one CVD event in a given period of time. Estimating years risk total, and why the update the score? Because in the previous score they estimate only the fatal, but here we will, in the new one score 2 will estimate 10 years for fatal and non-fatal events. In OP for all patients more than 70 years. If the patient has other non-cardiovascular disease risk mortality called competing risk from other diseases, which is not calculated in the previous score, so they are overestimated. The previous score will overestimate the 10 years risk, and we expect that the patient benefit more. That's why we change and this score is not fit for patients with cardiovascular disease, diabetes, familial hypertension, and heart disorder or chronic kidney disease, pregnant lady or secondary hypertension. Means that it's fit for apparently healthy. We need to know before we do that. The countries category. We have 4 regions: low, moderate, high, and very high risk. Libya is very high risk according to WHO mortality rate of cardiovascular disease, which means more than 300 per 1 million. We need to know the gender, male or female, smoking status, and BD, non-HDL cholesterol, which equal to total cholesterol minus HDL, the high risk lipoprotein. This is the recommendation for use of using the risk factor and the clinical condition on is recommended ICD. The whole region, we saw the dark red is the media and the dark red division, which means very high risk. We apply the risk stratification. We should see the BB, the blood pressure, systolic blood pressure, and the age, which patient, and he is a smoker or non-smoker, male and female, vertical line والhorizontal line هتعطينا كم الريسك ونشوف كل الريسك يعني فوق اذا كان هو high risk or low risk or moderate risk. accordingly هي الارقام موجوده من 2.5 5 بالتفاصيل. طبعا الثاني اللي هو الاوبي اللي هو for all patients اللي هو more than 70. هنشوف هذا البلدان اللي هي اقل ريسك اللي هي low risk. هنشوف اللون الاخضر اكثر من اللون الاحمر بعكس الثاني اللي هو deep risk معناها حيكون high risk. هذه الريجن اللي هي حتكون low cardiovascular risk. هنشوفوا هنا اللون الاخضر واجد، بينما لو نشوفوا هنا مقارنه هنلقوها معظمها حمراء الديب ريد او اللي هو ريد معناها هم الريسك بتاعهم زي الاخضر. لما حسبنا الاستيميشن ريسك حطلع عندنا اللي هي البرسنتج اللو تو مودريت كارديوفاسكولار ريسك في الايج نتاع الخطير حنلقوها اقل من 2.5. الفيري هاي كارديوفاسكولار ريسك حيكون اكثر من 7.5 وما بيناتهم حيكون اللي هو هاي كارديوفاسكولار ديزيز ريسك. لو نزول الايج 70 حنلقوها وصلت فيري هاي كارديوفاسكولار ريسك وصلت في 15%. هذه تعطينا الريكومنديشن ان انا هل نبدا تريتمنت ولا لا، بالاضافه للحط في بالي الريسكات الاذر ريسك. هنشوف مثلا لما انا في الايج ليس ذان 50 كان 7.5 بينما في 70 سنه كانت 15%. يعني كل ما زاد الايج الثيرشولد بتاع التريتمنت زاد. هنا مثلا حنشوفه في العمر 50 سنه لو تبعنا ومشينا فيرتيكلي هنلقى اللون الديب اللي هو الديب ريسك وين وصل في 7.5 بينما لو مشيت الايج 80 كان بيشخص في فيري هاي ريسك وصل ل 15. يعني الايج على اللي طلعناه من السكور استيميشن اسمه ابسوليوت ريسك. هل الابسوليوت ريسك هو اللي على طول نحسبه وهو اللي نقرر ايه تريتمنت ولا لا؟ لا، في حاجه اسمها ريلاتيف ريسك. ريلاتيف ريسك a way to explain the relation that increased cardiovascular risk due to the presence of certain risk factors in convention without. يعني زي مثلا واحد سموكر وواحد نون سموكر. That translation risk factor treatment decision is not recommended. The absolute risk demands the key for okay. The absolute reduction is better understand than relative risk. طبعا الريسك بتاع الايج هو الايج اللي الانسان نفسه بس عنده اكثر من الابسولوت ريسك، وهذه كلمه نستخدموا فيها بالشيء نوتن اوبريشن انه هو يغير اللايف ستايل او هو لو الشخص ما داش يغير هذه الطرق ممكن نستخدموها. اللايف ستايل اند تريتمنت اذا كان عالج او ما عالجش شنو هي الايج اللي حيكتسبها او الايج اللي هي حيختارها. طبعا هذول كلهم الريسك موجودات في ابلكيشن وممكن هم يطبقوها ويستخدموها كتول عشان نعطي انفورميشن ديسكشن يساعد البيشنت انه يغير اللايف ستايل بتاعه. الموديفايبل ريسك اكثر حاجه تكلموا عليها اللي هي سايكولوجيكال ستريس والإثنكتي والإنجن سكور اللي هي كالسيوم سكور وكراسة التراساوند. فدول ثلاثة هذوما ليش؟ لأن الريلاتيف ريسك بتاعهم ممكن يزيد أو ينقص الأبسوليوت ريسك. زي ما نقول نحن سايكولوجيكال ستريس نضربوه باثنين، يعني زاد الريسك باثنين. الإثنكتي ممكن ينقص أو يزيد زي ما قلنا مثلا زي الأفريكان بيبول لو ضربناه في طول 7 فحينقص. الفاميلي الثانية مهمات بس نخش عليهم ما يغيروش من الريسك من لو تو زي الأهل. هذا الريكومنديشن بتاعها إن إحنا لازم ترانسليشن كارديوفاسكولار شوت الانتي عشان احنا الاول كنا قلنا الهدف الاول انه نقصوا البي بي لسه 160 وبعدين على حسب الريسك لو هاي ولا ميديوم كان نحتاجوا ان نزيدوا انتنسيفاي التريتمنت او لا. هذول المودلز اللي نحن نقدر نساعدوا بهم البيشنت باش نقول له لايف بنفيت فروم لورينج سيستوليك بلاد بريشر او انه هو يغير ينقص ال بي ال شنو كم ياخذ من اللايف تايم او انه هو سموك سيشن.
دكتورة ثاني
تمام. هي هذه نفسها اللي حكيناها فيها على ستيب 1 وستيب 2 الانتسيفيكيشن مع الريكومنديشن. هذه الابلكيشن اللي احنا نقدر نستخدموها اللي موجوده وممكن نستخدموها. Thank you.
Thank you, Dr. Hawa. I'd like to invite the audience to present any questions to our speakers in this session. Dr. Sarah. لحظة بس تكون مدينة من الماس أو يسكتوا.
I would like to thank the speakers, Dr. Huda, Dr. Zaid, and Dr. Hawa. Nice. So, I just want a question regarding infective endocarditis, and I never heard about endocarditis team. And you've done very well, comprehensive presentation about infective endocarditis, which we need it. I feel this subject is very important for our practice, and every intervention for surgeon or pediatrician or physician who dealing with congenital, especially heart conditions, should be aware of the prophylaxis measure. And الوقاية خير من العلاج. Cure better than treatment. هذا البيزك بتاع اللايف. لكن اليوروبيان لو انت follow guidelines new guidelines nice guidelines يقول لك ما تعطيش antibiotic بكره. This is very important message. We are not applied to European or American or whatever new advance. Those people, they have their own way of living. They liaise with the microbiology before even starting antibiotics. They're not haphazard doing. But for our developing countries, it's not applied to our. And heavy message I want you to pass it to everyone. Even you mentioned the new nice guideline, but it's not our practice to advise physicians just go just good oral hygiene and dental visit. It's not applied in our country. Good oral hygiene نظف اسنانك وما تديرش تاتو وما تديرش الكلام هذا preventive measures. It's not applied in developing countries. يعني نحن we not belong to the other world. النقطة هذه لأن النقطة حساسة. تحط بسميكر $1,000 وبعدين infective endocarditis ولا CRTB £35,000 وبعدين end up of infective endocarditis. يعني it is a message of the day in this infective endocarditis. You've got to be aware that we have to take the maximum prevention in the top of the other people what they are doing. And we should follow very restrictive measures, very crucial measures before we get these guidelines. And it's very important message that antibiotics should be given. يعني مثلا واحد جاي بايكاس اللي هو في الظهر يخطف على واحد جاي اوبريتد congenital heart disease فالت والا فونتان الله عنده كوندوز وعنده شغل مديور من قبل antibiotic is a must. يعني هذه المسج معناها يعني ريت everybody فرصة في أي وقت.
دكتور أثمان, do you have any تعليق؟
Thank you, Dr. Said. طبعا endocarditis seen mentioned since 2015 في اليوروبيان سوشيال جايدلاين، لكن هي endocarditis seen أنا يعني حبيت إن I raised this point just because wide spectrum of presentation of endocarditis patients. Yani sometimes come with neurological symptoms rather than cardiac symptoms or rheumatological symptoms, rash or something. Other points if you decide to treat patients conservatively without surgery, with antibiotics, you have to share the cardiac surgeon from start regarding indication when you refer a patient. Then I want to tell the story of this patient diagnosed 4 months back here in Derbi. I diagnosed this patient. Yani he spent 1 week moving between polyclinics with the symptom with fever. And when he presented to us, there is complete rupture of vestibular and interlateral cortex tendon with severe mitral regurgitation. Unfortunately, this patient referred to the hospital. And they spent 2 days in hospital, and then 2 days in another hospital, and then died. So I feel in sharing the experience between cardiac surgeon, cardiologists, and microbiologists to reach the patient to the safe side. يعني هذا فقط البوينت اللي بنتكلم. لكن الانترفيرنس حتى في مصر بيابلاي الانترفيرنس يعني هو واحد من ضمن
Any other questions from the audience? I'll just comment شوية على موضوع endocarditis. Endocarditis is a very serious diagnosis. It's a very serious disease. The mortality rate is very high. In our practice, we face a lot of problems. Most importantly is that we don't have reliable microbiology results. I mean, even when we take blood cultures to get accurate results for the coding organism or how are we to manage these patients, which is, unfortunately, this is the cornerstone of managing infective endocarditis successfully. But when it comes to antibiotic prophylaxis, and I get Dr. Salim's point, in our world, we are a third world country and probably the hygiene and everything else is different. We cannot apply what the Western world uses in our situation. But here is the idea. I think when they change the guidelines, that is, we only use antibiotic prophylaxis for high-risk patients, that is, the patients who have mechanical valves, who have synoptic congenital heart disease, or patients with previous infective endocarditis, because several trials have shown that when you give prophylactic antibiotic, you're not really making a difference في الأوتكمز على البيشنت. يعني مريض أعطيته prophylactic وأعطيته prophylactic antibiotic مش هيفرق. If they're gonna get infected endocarditis, they're gonna get it. And the other thing is that the daily brushing of your teeth actually this causes bacteremia. If you have bad gingiva, كل مرة واحد يغسل أسنانه